I'm aware that the use of biologics for the treatment of asthma has been growing in recent years. Could you tell us, please, where do biologics fit in the treatment pathway for asthma?
Biologics are actually quite an exciting aspect of managing asthma. So the first biologic came out actually in 2005. So that was omalizumab Xolair. So that actually has been around for a number of years. And that sort of targets more the allergic aspect of asthma. So works very well in people who have atopy, perhaps associated urticaria, eczema, allergic rhinitis. So very much where allergens are driving people's asthma. More recently, we've got a number of biologics which target more the type 2 inflammatory aspect of asthma, which is what I was talking about earlier about eosinophils. And these are medications which, again, are given as an injection, often subcutaneously. And they work in helping to reduce exacerbations and often reducing the amount of oral corticosteroids we have to give people for exacerbations, and can be life-changing for some people, can really improve people's asthma control. And then more recently, we've got another type of biologic which targets a slightly different pathway as well within asthma. So it's a really evolving area of research and excitement really within the field to think that we can offer people with asthma new treatments that can really help to prevent mortality and morbidity of the disease.
You've mentioned that you're an independent prescriber. Could you tell us now what this means in practice? Can you prescribe anything?
So I've been an independent prescriber since 2008, and I can honestly say to you that I probably use my qualification nearly every day. So it's really made my role as a pharmacist, it's expanded, and it's helped my relationship with my patients and also my relationship with the other members of the multidisciplinary team. So what does it mean? I guess that it means that I'm actually responsible and actually accountable for the prescription. So I'm assessing the patient. They may be diagnosed with the condition or they may not. I'm looking for differential diagnoses, making sure that I'm prescribing at the right time for that patient, making sure it is the right drug that I'm using for the right condition. And I think for me, it is about that accountability. For years as a pharmacist, you say, oh, excuse me, would you mind prescribing this? Or could we do that? And now I can still do that as part of my role, in terms of teaching other members of the multidisciplinary team, but I'm actually putting my name against that prescription. And I think that's really important, to take that accountability.
So what difference does it make to your relationship with a patient?
I think when you're discussing medicines with patients, and a big part of my role, particularly in the severe asthma clinic, is around how do I motivate my patients to take their medicines and to use their medicines correctly? How do I get them to understand why this medicine is important for them as an individual? So, I think it's about that sort of shared decision making. I want to understand what my patient feels about their condition. I want to understand what they feel about their medicines. What do they like about them? What are their beliefs about medicines? Some people just do not understand about prevention, for instance, and prevention in diseases like asthma is absolutely key. So you have to have that understanding. You have to talk to patients about that. And I think during that consultation, to be able to then say, okay, let's look at your medicines. Let's see what suits you better. What do you like? What don't you like? What can we do to help you? And then to finish that consultation with a prescription that they can walk away with, or even if it's not a prescription, but it's a statement about them doing more exercise or health promotion type of aspect. But I think it's around just making sure that they take on board a little bit more what you've got to say, and it's that shared decision, and it's nice to have that prescription to go away with.
And if you are prescribing drug treatments, isn't there a risk that this will result in de-skilling of junior doctors?
I mean, the first thing to say and is that I only prescribe medicines that I'm competent to prescribe within my area of practice. So, in fact, my number of medicines that I prescribe is actually quite limited in a way. It's very much inhalers, it's, some aspects of antibiotics, steroids, things like that. So I'm not prescribing everything. I think from a junior doctor point of view, I think we can teach as part of that prescribing process. So it's about trying to work together as a team. What I bring to a team as a pharmacist is different to what the junior doctor will bring. Part of that prescribing, I can show them perhaps how to prescribe, why my prescribing decisions, what am I thinking when I'm going through that, writing that prescription, because that's what we need to teach people, to go through. Have I thought about this? The renal function, the liver function, the patient, could the patient use the medicine, dexterity, all these type of things that we as pharmacists perhaps think through before we write that prescription. That's what I want to share with the doctors. So I'm not de-skilling them. Actually, by the process, I'm showing them how, and hopefully, enhancing their competency.